All right, are you guys seeing the title slide here? Yep, okay, perfect. Well, I'll get started just to respect those of us that were jumping on time, and we'll let the other guys roll in. So we had our last spine discussion was on thoracolumbar deformity, right? And we had Dr. Koski just sort of walk through a whirlwind of everything about thoracolumbar deformity, but the principles, if you remember, came back down to sort of understanding alignment. So we have some clarity on what optimal or what average or normal alignment is in the TL spine. And then trying to start down a decision tree about how we tackle deformity, malalignment in the thoracolumbar spine. And that led us into conversations around, when do we think about osteotomies? When do we think about anterior posterior reconstructions? Like, what are the tools that we bring to the table when we think about the different sort of concepts in deformity when we start to assess the different types of deformity? So that same thing we went through in thoracolumbar, we'll kind of walk through the same concepts in cervical. And there's some nuances that we'll cover along the way. But I'm hoping when we finish, we come back full circle, you'll leave with some common threads between the thoracolumbar deformity conversation and then the cervical deformity conversation. So with that, there's 3 goals. I always like to try to have 3 goals for you guys. First is that we run through and we identify the impact of deformity and the causes of deformity when it comes to the cervical spine, right? We define, second goal was we define a strategy for how we evaluate cervical deformity. And that's where we'll see some mirrors with thoracolumbar. And then third is to think about what are the factors that play into surgical decision-making. So let's, as we leave the talk, make sure we can recall at least a few of the critical determinants of surgical decision-making. And as always, this is an informal conversation. Feel free to unmute yourself, jump in, ask questions along the way, as opposed to maybe waiting until the end. So that way we can tackle them in real time. And as always, the more conversation we have, the more learning I think happens. Let me close this. Okay. So some of the guys that have been on the call before or has been on this lecture before will recognize this case, but it's, I think, one that's really telling in terms of understanding causes and impact of deformity. And we'll come back to Russell as we go along through the discussion, but this was a patient of mine relatively early in my career. He was a 54-year-old gentleman, was a laborer, actually came from one of the reservations in Southern Utah, and was having some progressive troubles. He had a hard time keeping his head up, which then led him to have a hard time driving. He had a hard time eating. So he was, not eating great, still drinking lots of milkshakes and stuff, but not eating well. And then that ultimately led to trouble socializing and even trouble working, right? Because for a heavy labor position, his head was not in an optimal place. And so if we look at his alignment, these are sort of midline and then flexion and then extension images. In the middle, this is his normal posture, right? You can see he's got this combination of kyphosis where potentially his whole thoracolumbar spine into his cervical spine is kyphotic. His head is translated, so it's shifted forward over his thoracic spine. And ultimately, this leads to what you'll see reported as a chin on chest deformity. Hey guys, I just got a notice that popped up that said you may or may not be seeing the slides. Can somebody just give me a thumbs up if you're seeing them? Okay, all right, I got at least one. Okay, perfect. If something's going on, let me know. There's a bunch of things popping up on Zoom that I haven't seen pop up before. So we're going to talk about an alignment and what's abnormal. Let's start with what's normal. And so if we think about the general number that's out there is the idea that cervical lordosis should be somewhere between 20 to 30 degrees, okay? Like in the thoracolumbar spine, where we think about average numbers being between 40 to 60, the cervical is about double that, about half of that, about 20 to 30. understanding as we dig in, we're going to understand there's a lot of nuance to this, that not everybody's going to have the same amount of cervical lordosis. And there are some global factors that drive this, but in general, we want to see a relatively lordotic spine. And we got to remember it's a balancing act between the skull and the cervical spine. And the analogy that's been given before is like it's trying to balance a bowling ball on a bowling pin, right? If you think about the osteology of the upper cervical spine and the cervical spine, it's meant to allow for lots of degrees of freedom of motion. So the joints aren't constrained, which means that the alignment really can go in any way, shape, or form. And the only thing really keeping this balance in place is probably the neuromuscular control that patients have. There are some conditions we'll get to where we disrupt that neuromuscular side, or we disrupt the structural side. And then we've got this really sort of potentially unstable situation with this bowling ball teetering on the bowling pin, and it always falls forward. Like I remember back in the days of when I used to do trauma, we used to say that everything goes into varus, right? Everything falls into varus. In the spine, everything goes into kyphosis, right? And so the gravity kind of ends up winning. So normal biomechanics, if we think about load transfer across the spine, we see that about 1/3 goes to each lateral column and about 2/3, let me add that up again, 1/3 to each lateral column and 1/3 to the anterior column is the usual division of force. And what that means is for most people, because of the lordotic angulation, the normal weight-bearing axis is a little bit posterior to the posterior vertebral line. Okay, so this is normal biomechanics, equal load sharing, anterior and then each lateral column like a tripod, and then weight-bearing axis a little bit posterior to the apex of the lordosis. When it comes to kyphosis, there's a bit of a biomechanical sort of vicious circle that people can go through, right? There's some event, something causes that axis of rotation to shift a little anterior, which then puts all the other structures at a mechanical disadvantage. The facets are seeing more tension than they're used to. The anterior column seeing more compression than it's used to. The balancing cervical musculature is at a complete mechanical disadvantage, right? Because it's been stretched probably beyond its optimal fiber length. And so that then begets more kyphosis, which then leads to more weight transfer anterior, load transfer anteriorly, which leads to this mechanical disadvantage, and so on, which is why kyphosis is sort of a self-fulfilling prophecy once it starts. And just for perspective, when we think about different degrees of kyphosis, we want to think about what's the severity and what's the impact of that degree of kyphosis. Most of us live on the left side of this makeup chart, right? Make-believe chart, because we're looking at it on our phones all the time. Many of us will hopefully never end up on the right, but a lot of our patients with pathology are going to be somewhere in the middle. And we got to think about how much severity are they having and what's the impact of that. The other thing we want to think about is neurological involvement, right? So we didn't talk too much about this actually in the thoracolumbar discussion. And that's because in general, thoracolumbar deformity outside of radiculopathies and spinal stenosis usually by itself doesn't cause a neurological event. In this setting, you've got tension on the spinal cord, right? And you've got a compressive force anterior to posterior going on simultaneously. And so the combination of that too leads to neurological dysfunction, myelopathy. You might also even have an ischemic component, right, with those deforming forces. And so do we know any link between cervical balance and neurological outcomes? Well, we've got a little bit of data, and we're going to come back to this study a couple of times because truthfully, there's some things in the literature, but not an overwhelming amount, and certainly not a defining amount yet. So this was a study where they went back retrospectively and looked at patients who had surgery for cervical myelopathy. And I think this specifically was mostly posterior-based procedures. And they ran through a bunch of radiographic measures to try to see if they could correlate any of the radiographic findings preoperatively and postoperatively with functional outcomes. And what they identified was that patients who had worse cervical balance, so the more forward their head is, and we'll get into some details here, the more forward their head is, the worse the neurological outcomes were. Okay, both in terms of MJOA, which is a pretty good validated measure, and then Neuric Disability Index, which is a not so great validated myelopathy measure. So there is some link between balance and functional outcomes, at least in patients who have had surgery for cervical myelopathy. There's a link between cervical positioning, posture, and swallowing. So this was an interesting study that was done a while back, almost 10 years ago now, where they took patients through different ranges of motion, flexion and extension, retraction, extension, and protraction of the neck. And all they did in this study was measure oropharyngeal space. And what they've identified is that certain positions improve the space, other positions make it a little bit worse. This hasn't been tied directly to outcomes, but the point reason I include the slide is to take home the notion, at least, that positioning of the head and neck can have an impact on swallowing function, right? That's the link, is that with a severe malalignment, swallowing can become a challenge. And if you want to convince yourself of that, get a glass of water or whatever you're drinking and try to take a sip with your neck flexed down all the way and see how easy that is, right? It's a little hard to kind of get that down versus trying to have your head extended. Similarly, trying to have a drink of water with your chin tucked in versus your chin extended out. And you'll understand intuitively that there is a link between cervical alignment and swallowing function. And then quality of life, this is sort of what we're trying to measure. It's not been measured great. There is some work that has been done in cervical deformity patients, identifying that patients with deformity have greater neck disability, they have more neck pain, they may have more neurological involvement, but overall, greater details around like social health and mental health and physical health probably are still lacking. And part of that is that we're trying to still get to, in the spine community, some consensus about what is a cervical deformity and what is not. And we'll talk about that as we get to some X-ray findings and we get to some X-ray measurements. But the takeaway, this is that first point, which is to understand that cervical alignment matters. It has an impact on quality of life. It likely has an impact on neurological function. And it certainly impacts everyday functions that we may not think twice about, like swallowing. Any questions on that? Let me pause. That's the kind of the first third of the talk. We'll sit in awkward silence for a second, and then I'll keep going. All right, well, if they come up, jump in. So, and we think about next step is understanding what the causes of deformity are. And it's the sort of standard list that we probably all memorize when we're junior residents of what's the cause of any orthopedic malady, right? It falls into one of these buckets of either degenerative, traumatic, iatrogenic, a congenital deformity, or then tumor and infection. Did I leave something out of that list that you guys usually run through when you're thinking about causative factors for any conditions? It's not a trick question. I'm just asking if I actually left anything out. I'm saying some head shakes, so probably not. Okay, if you think of another cause, let me know. But this was always my cheat sheet when I was a resident. If anybody ever asked me what were the potential causes for almost any condition, this is what in the adult population, this was what I pulled out of my head. And it generally works pretty well for most orthopedic issues. So degenerative kyphosis, this is the one that we'll see the most, right? It's the most common arthritic change combined with maybe some other factors. But what happens in this setting is that with spondylosis, with a loss of normal disc height, with the development of osteophytic changes, the subaxial spine will usually tend to go into kyphus. You'll see a little bit of kyphosis form. And then that will beget one level after another to become kyphotic, and you'll eventually get a gradual loss of lordosis. Occasionally, these deformities will actually stabilize themselves over time. They won't progress to sort of severe chin on chest type deformities like we saw with that first guy, because those osteophytes will stabilize over time. The other one that we think about often, more so in children than in adults, but it's certainly on our mind with a lot of procedures, is this concept of a post-laminectomy kyphosis. So individuals who have a posterior-based cervical laminectomy without a fusion, and might they or could they go into kyphosis? And I think this still is a concern that many of us face or are worried about. It might be a little bit overblown in the sense that there's probably some patients who can tolerate a laminectomy posteriorly without going into kyphus. But the reality is we have a hard time identifying who they are ahead of time. So the fear of this condition is oftentimes why we will do an index fusion at the same time that we do a posterior cervical laminectomy. The other category are sort of infections and tumors. And this is a patient we took care of at Northwestern a couple of years back, that came in with a pretty nasty retropharyngeal infection, as well as then pretty substantial bone destruction that ended up being tuberculosis. But he had come in with pain, and this is many people will present in these settings for infections and tumors early on with pretty severe neck pain, right? This really bad insidious pain like we see in other locations of tumor involvement or infection involvement. The difference being they'll progressively develop deformity, and with that, they'll progressively develop neurological deficits. And oftentimes we'll catch them either really early in the stage, really early on, or we'll catch them like this poor guy at the end stage when they're in the emergency room, with at least a hemiplegic or total plegic event. So this next group is sort of the neuromuscular group, which is probably the second most common cause for cervical deformity. And these are folks who have problems either with a primary myopathy, or more commonly than that is a neuromuscular junctional disease. So myasthenia gravis is always one that we think about when we identify somebody with a chin on chest deformity. In the neurology world, this is called dropped head syndrome, which I used to laugh at, but actually think is a pretty good way to describe, how these patients present. When they lay down, their head can obtain completely normal alignment. When they sit up, if they're holding their head up, they'll be able to keep their head relatively neutral. But if you let go, their head will just flop. And so when you see that sort of a situation, you have to think, could this patient have a primary neuromuscular disorder? And you really have to make sure that that's identified and worked up before you consider any intervention, right? And this usually takes a while to sort out exactly what the underlying problem is. So ankylosing spondylitis is probably the most common cause of cervical deformity, and it's one of the most common reasons we surgically correct large chin on chest deformities is ankylosing spondylitis. And I think, we're fairly familiar with it in the sense that it pops up on the OIT every year. It'll pop up on your in-training exam every year. We talk about it a lot in trauma in the sense that ankylosing spondylitis in the setting of trauma, it's easy to miss those injuries. And those injuries can be quite dramatic, quite severe because of the mechanics of the spine. The other thing it does is it creates gradual compressive deformity, and it sends people into kyphosis, both cervical and thoracolumbar kyphosis. The mechanism for why that happens, we actually don't know, right? There's a lot of theories that as you get a little bit of this off-axis load shifting, you start to develop compression fractures or compression on the anterior column, which leads to more and more structural change. And that theory is out there, but whenever we see their spines, they don't look like compression vertebral bodies. They look like nice squarely shaped vertebral bodies, but with this bridging bone. So I don't know that we have a good answer why this happens in ankylosing spondylitis, but it certainly does happen, for sure. And it's a thing you've got to consider if you've got somebody that you're seeing with a substantial deformity. When it comes to ankylosing spondylitis and treatment, there is a mixed response currently to biologic agents in terms of preventing neurological decline, preventing deformity progression, I should say. So we oftentimes still think about this as a surgical problem. This was a couple of years back, I think 2015, the American College of Rheumatology put out a publication basically saying that we should never do osteotomies for ankylosing spondylitis because of the low quality evidence. And that's actually true. There's not great clinical data, clinical evidence that surgical intervention makes people substantially better. We're getting there, but we don't have a ton of data on it. But they then go on, and that's again, lack of high quality evidence with relevant outcome measures. And that's totally where we need to be better. They mentioned that there's lots of reported complications in this group, and there totally are. But they also put a little disclaimer there, which is that folks with severe kyphosis, a loss of normal gaze at specialized centers and surgeons with extensive experience, with those disclaimers, they felt, okay, there's that subset of patients who benefit from surgical intervention. So we have a situation where the docs who are primarily taking care of ankylosing spondylitis have some agents that they're on their behalf, the biologic agents that might help, but we don't know for sure. Have some doubts about the work that we do as surgeons. Is it really helping these patients or not? And yet they also appreciate the quality of life impact and the idea that for some of these patients, it's worth a try, right? It's worth taking them through if the hospital and the surgeon has lots of experience. But there's lots of unanswered questions here. And I highlight this before we start talking about sort of a workup for the deformities and how we break them down, or framework for that, just to point out about how many unanswered questions there is in just this small little niche of spine surgery, right? We talked about, we don't know why deformities develop in this population. We don't know what the risk factors are. Not everybody with ankylosing spondylitis goes on to deformity progression. We really don't know what the therapeutic impact is of the newer medications that have come out. And we don't have great prospective studies with validated outcome measures. There are some, and there are a couple of great multi-center efforts that are going on that are leading us in this direction. But again, a lot of the problems come back down to the inclusion criteria and, what's a deformity and what's not a deformity. And that's what plagues the current literature. So in terms of, we covered that already. In terms of the workup, I'm not going to spend too much time on this. Suffice to say, we're going to go through our standard radiologic workup, plain films, MRI, CT myelogram if we need it, CT to understand the bony anatomy. A couple of unique aspects when it comes to assessing patients' alignment, both with x-rays and with examination, is to see how much flexibility is in the cervical spine. You can do that a couple of ways. With x-rays, you could lay them flat. You can get a bolstered x-ray, so you put a bump behind their scapula, behind their thoracic spine rather, and you see how much extension you can passively get. You can do traction, so you can put these patients into Gardner-Wells tongue traction and see how much mobility you can gain just through positional changes in traction. You can also, just by examining them, see, right, that if you see somebody with a chin on chest deformity and you're not sure if this is a rigid or a fixed deformity, you can just lay them down on the table and let them gradually bring their head back. And I've had some times where I'll have them lay down and I'll come back and check on them 15, 20, 30 minutes later, just to see how much, you can stretch them out with gravity. And that becomes really important as we think about our treatment algorithm. In terms of radiographic measures, there's a couple of different categories of radiographic measures. For the purposes of the discussion today, I lumped them into sort of thinking about upper cervical measures and then subaxial measures, and then sort of global measures. The global measures tie in with the subaxial measures a little bit. The upper cervical measurements, which is the occipital cervical angle, the OC2 angle, and then the angle between C1 and C2, I think are interesting, but they're pretty niche, and I want to focus more on the subaxial conversation. That's thinking about what's the Cobb angle, so C2 to C7 Cobb angle, which you see in this sort of line right here, labeled as Cobb angle, and the T1 slope. So T1 slope is sort of an analogy to sacral slope. It's the idea of what does the position of T1 look like in space. So that as T1 is more vertical, as the T1 slope increases, more cervical lordosis is needed to maintain a balanced head. Whereas a flatter T1 slope, you don't need as much lordosis. Very similar analogy to what we talked last time about around pelvic tilt and sacral slope. SVA is the other one, and this goes back to, I think, that same study that we had talked about earlier, looking at outcomes and balance. And so if we look at the right side of the chart here, right, we identified that patients who had a C2 SVA, so a plumb line from C2 drawn to the back of the C7 T1 disc space, if that was more than 4 centimeters, they had worse outcomes with regards to pain and neurological involvement. On the other hand, on the left side of the screen, if they were well within that 4 centimeter zone, they generally had much better outcomes in terms of NDI and SF36 PCS scores. So getting people balanced, getting them out of kyphosis, getting their head positioned over their thoracic spine over the last 5 years to 10 years has become increasingly apparent. And for me, in the last 3 to 4 years, really is now a mainstay for one of the things that I think about and I do, for these procedures. And so I'll share one example. So this is that patient we talked about earlier who had come in with the pathologic fracture from an infection. This middle slide is what it looked like after we did an anterior and then a posterior reconstruction on him, just the instrumentation. And you would say, well, that's pretty good alignment. And I think this is how I would have fixed him into this position. But if I get really critical, his C2 body is a little bit forward, not terrible, probably still within that 4 centimeter mark. But where I'm heading now with these procedures, and when you come to the OR with us, you'll see this, is that we're pushing to really get lordosis back, right? We're really trying to get correction, both translational correction and lordotic correction in this setting. So that where the middle slide would have been where I was a few years ago, the slide on the right is where we're trying to get these patients from a postoperative standpoint, with the hope being that with a better restoration of lordosis, better translational alignment, they'll have a better outcome. And that's at least based on what we see in the literature so far. It certainly seems like that's the trend. Even if we don't have great level 1 evidence, it's the trend in that direction for sure. T1 slope we talked about already, right? This concept of foundation. So if you've got a nice level ground to your cervical spine, you don't need as much lordosis. If it's highly tilted, you'd need more lordosis. And then the last measure, which actually might be, it's the least impressive because it's the least complicated, but it actually might be the most meaningful, is the chin-brow angle, right? So literally taking an angular measurement from this line here, which is the vertical, okay, to a line that goes tangential across the chin and the brow. And what does that angle subtend to, right? Many of these patients will come in with an angle of anywhere from 20 to 30 degrees. And the goal, at least in terms of maintaining horizontal gaze, is to get them to a goal of about 0 to a little bit less than, into the slightly negative range. So anywhere from 0 to -5 degrees, you want them to be able to see down. Otherwise, they're looking up, all the time if you overcorrect them. So chin brow angle, while we have all these other radiographic measurements we just talked about, right? Sorry to go back, but SVA, T1 slope, Cobb angles, upper cervical alignment. The only thing that we can reliably count on to help patients' quality of life right now is chin brow angle. So getting their head into a good position, getting their eyes horizontal so they can see ahead and see the ground. And this is the measurement, at least in current state, that we use in the operating room to guide us towards, what is optimal alignment in the OR before you leave. And I've got some slides coming up that'll kind of show you some hints about how at least I think through that in the OR. There is a deformity classification system that came out about 6 or 7 years ago. It's being used primarily by the same authors in their larger sort of multi-center studies. But if you look at the drivers of the deformity, they're talking about on the left-hand side here, where is the deformity, right? And what kind is it? Is it coronal? Is it sagittal? They get into SVA, chin brow angle, cervical lordosis, and then the severity of myelopathy, right? So it's very similar things that we've just talked about are, again, the factors that we start to really hone in on that drive surgical decision-making, as well as potentially driving our goals of surgery for this population. So with that in mind, let's spend the next maybe 15 minutes, 20 minutes before we wrap up, just going through a walkthrough for how at least I approach cervical deformity, if that works. Does anybody have any questions where we've been so far in terms of understanding the causes, understanding how we assess these patients clinically and radiographically? Let's make sure we're really at least comfortable with that. I don't expect you to be experts in it, but if I've said something that's completely tangential from where your head's at, let's speak up and let's understand it better.
Yeah, Dr. Phil, I have a quick question. So there's like papers out there that, they say you should really hang your hat on for, for myelopathic patients, really restoring lordosis, or there's some that say, restoring C2 SVA is the holy grail. In your opinion, is there one that you should really hang your hat on if you had to choose one in the operating room? Just because like there's studies out there that be like, well, MJOA and then their NDI were superior if you, fix one or the other.
Yeah.
I'm just curious about your opinion.
Yeah. So the honest answer is that there's no holy grail, Eric. People will be absolutely convinced that the number they use is the right number to use. And I think a lot of our literature is fighting that problem right now, is that we've got a lot of really good measurements. We've got a lot of good equations when it comes to trying to solve for this problem of what do I need to fix? And the reality is the correlations between those measurements and the patient outcomes is really low. Right. If we look at the R squared values on many of these, they're, much less than 60%, sometimes as low as 30% correlation. So we've got very little predictive power in any of these radiographic measurements, is the honest answer. What are the goals? Let's get to that here, right? Which is like, what do we want to do? Well, we want to prevent these deformities from happening. We want to get, Eric, I didn't realize I didn't answer your question. That's my bad. I should have answered it. So there are no single measurements that are predictive of our outcomes. But your question was, which one do I target, right? Yeah. If I had to choose between lordosis, like C2 to 7 lordosis, and a C2 plumb line, I'm trying to get C2 over T1.
Okay.
I'm trying to get them out of that sort of protracted position and into a more retracted alignment.
Okay.
So sorry I didn't answer your question, but I hope that makes up for my attempted dodge.
Dr. Patel, real quick.
Yeah, buddy.
Do you have an algorithm that you use for indicating these patients for surgery? Because I feel like that's one of the most complicated parts of this is they tend to be like older, more debilitated patients, and you're talking huge surgery. So how do you kind of broach that conversation with these people?
Totally. If you give me about 8 minutes, we're going to see the algorithm that I go through and how we think about not just how to do the surgery, but when to do it. So I didn't plant. Joe wasn't my plant. It was just a perfect lead in into what we're going to talk about next. So in terms of the goals of treatment here, so I always like to start off trying to understand what are we trying to accomplish when we think about a surgical reconstruction for a patient with a cervical deformity. I mean, obviously prevention. So we don't want to create a deformity. As we talked about, iatrogenic deformity is real. And so we don't want to create a deformity. That's why we try to really pull the head back. We really try to get lordosis, try to get optimal restoration of alignment in the OR. But let's talk about then a patient with deformity. We want to get them neurologically decompressed. Many of these folks will have myelopathy or a radiculopathy. So we've got to get their neurological decompression done. That's probably the most important thing we do for these individuals. We do want to restore both local and global sagittal alignment. To Eric's question, which one do I think matters more? Mostly sagittal, global sagittal alignment, except in some cases, right? If you have somebody with a very focal or localized deformity and they're myelopathic because they've got this spike of bone pushing up against their cord, you got to fix that local issue as well. But all things considered, the global probably matters. And then creating a situation for long-term stability and stabilization, right? And that's our fusion and fusion constructs. So this is my algorithm, and it's gonna ring true to how I look at thoracolumbar deformity as well. So I've got probably three main steps when it comes to how I work through decision-making in the setting of cervical deformity. The first step, after we've already talked to the patient, after we've already assessed, how much this is impacting them, and we figure out what their motivations for surgery are. As I'm trying to make my technical decisions, my first step is to figure out, is this a flexible curve or is it a stiff, rigid curve? And let's talk about that. Second thing is I want to look at the location of the deformity. Is this a mid-axial deformity, localized, resulting in a neurological problem, or is this a global deformity? And that'll also then drive not just where, but how we create a restoration of alignment. And then the third one is thinking about, wow, well, based on number 1 and number 2, how does that drive my decision-making on the best surgical approach? So I try to go stepwise in that manner: flexible, the location of the deformity and its neurological implications, and then how does that drive my approach? Anterior or posterior, combined? Does that drive my osteotomy technique? How does that drive our levels of fixation? That's when you start to get to the more complex kind of levels of decision making. But the other ones, which are the take homes, is this a flexible curve or not? Where's the deformity in the cervical spine? Where is it? Is it mid cervical? Is it global? Is it somewhere in the thoracic spine? These are the things we need to figure out. So step one, flexible fixed or flexible deformities. I would take a flexible deformity any day of the week over a fixed deformity in terms of being the more reliable way to, or the more reliable problem to tackle. So how do we figure that out? So we talked about supine examination, right? Letting the patient lay down and just see with time, does their head gradually come back, right? Second thing, traction, we talked about, manipulation. You can lay these patients down and with your own hands carefully, see how much correction you can get with them laying on a table. You can look at your CT images to see, are there areas of ankylosis, right? Are there spots within this deformity where the facets have fused themselves together, or the disc space has fused itself together? And that'll give you an idea about motion and about fixed versus flexible. So this is an example that I took from, I think one of the guys at the clinic let me borrow this one years back. They had somebody who had a prior laminectomy, which is this top left image, and they were going through this chin on chest workup. This is in the operating room, but that patient, just by laying flat, and in this setting, by getting segmental correction through each disc space, they were able to get that kyphus to at least neutral, right? And then they're able to lock that in, hold it in position. In hindsight, I would look at this picture now and say, we could have done even more. We could have probably done a lot more to drill out the facets posteriorly, correct through 2-3. So there's probably even more I would do in 2022, but this X-ray is probably from 10 years ago. And so this is an idea of where you have a really imposing looking curve on the top left, but just with traction and with segmental correction, you can get a really good restoration of their at least more normal alignment, and you can get their cord off pressure. So after we've decided if it's fixed or flexible, we have to ask ourselves, where are we going to make the correction? So there are some deformities, like on the left, where you see the apex of the deformity is in the subaxial spine, and it's a localized deformity. So we're going to probably need a local corrective maneuver, right? Correcting this patient by adjusting their T1 slope or by changing their cervical thoracic alignment won't really account for this focal kyphotic deformity, nor will it address the neurological issues that likely go with it. On the right side, you've got the opposite scenario where you've got this global deformity. And you've got the hint where really, if you kind of turn your head really way to the side, or back in the day, you just take the X-ray and rotate it, you'd see, well, there is kyphosis through the subaxial spine, but there's a lot of deformity coming from the cervical thoracic junction, and maybe even as you go lower into the thoracic spine. So the second question is, well, where do I make this correction? And that's driven by where is the problem? And then the third thing is asking yourself, well, what are the approaches for this? We already saw a couple of cases of an anterior posterior approach. Those work really nice for flexible deformities. They work really nice actually for sometimes for mid-cervical deformities when you've got to do an anterior osteotomy and then a posterior osteotomy. But the workhorse for most of our osteotomy corrections are posterior-based osteotomies. And this is, again, where it's going to sound similar to what we talked about in the last lecture on adult thoracolumbar deformity. The difference between posterior-based Ponte or Smith-Peterson osteotomies, which in the cervical spine, just to make it more complicated, is called a Simmons osteotomy. Or is this more of a pedicle subtraction osteotomy, right? And that depends on where's the moment of the center of rotation of that deformity correction. And then not to forget to also look at the entire thoracolumbar spine. So I think even if we see somebody for a cervical deformity, we're going to try to get full length cervical thoracolumbar films on them to look at global balance, to look for any concomitant thoracolumbar deformities, and as well as to get a gauge for where are they at with regards to their hips and their knees and their lumbopelvic alignment. So while we like to, and we need to present these conversations as though, well, here's cervical deformity and here's thoracolumbar deformity, and they're two separate issues, they're really not, right? It's a continuum of concepts, a continuum of disease pathologies. And so keep in mind, just because they're coming to you for a neck issue, that you need to assess their overall global spine. Joe, this goes to your point about how do we make a decision on when to operate? I think that the real take homes is that we're not operating on an X-ray, right? No matter how bad the X-ray might look, that's not going to drive our decision to do surgery, and it really never should. I put this in just to dig at some of the deformity guys out there right now. We're not solving equations, right? There's all kinds of regression analyses, all kinds of regression equations that are both complex and simplified, that are trying to get to the questions that Joe and Eric had asked about, which is, where do we make our correction, and does it matter, and how do we make it? And right now, we don't know the answer to that. It doesn't mean we're not asking questions. It just means that it's not about an X-ray, and it's not about solving for an equation and letting an equation drive your goals for correction. But I do think we're looking for human-centered solutions. So how do we take our clinical information? How do we take our radiographic information, which is really important? How do we take the impact on patients' lives, which is where we started the conversation today? And then how do we take patient-reported outcomes maybe as a human-centered approach of assessing problems? And how do we lump that all together with maybe their medical history, as well as their bone health history and these other factors that go into the decision-making process? Let me skip that for now. And so those other conditions really are about, we talked about bone quality, soft tissue coverage ends up being really important. Many of these patients may have had surgery before. What are your capabilities for neuromonitoring? These are high-risk procedures when you talk about osteotomies. You've got to have, not just as a surgeon, a good set of hands, you've got to have a great anesthesia team that knows how to do neuromonitoring. You have to have good neuromonitoring folks, the physiologists and the neurologists who know what you're up to. You got to be able to optimize or identify the medical comorbidities that matter and optimize them ahead of time. And then this last part, really important, you got to figure out what the patient's goals and what the patient's expectations are, right? A patient with a chin on chest deformity or a sagittal imbalance whose only goal is to get out of pain may do well with the surgery, but not great. Certainly not as well as somebody whose main goal is to look forward again, right? To get better alignment for the sake of being able to interact with the world better. They can eat better. Those are patients where we know we have very achievable goals. Joe, does that answer your question?
Yeah, it does. I mean, I just think every patient with these is so complicated that it's, it takes more than a 15-minute conversation to talk about these things.
Totally.
Yeah, they're tough.
And these are folks that you guys might see a window of time where they only see one of us for a few minutes, but we really see these patients a number of times before we get to surgery, right? Part of that is getting them through the workup. Part of that is getting other sets of eyes on the patient. I know for me, when I see somebody with a cervical deformity, I get super excited. I want to fix it. I want to correct it. I want to get them better. And I might be missing some of these really other important other factors. So getting other sets of eyes on the patients matter. If it's somebody with a dropped head syndrome, I didn't add this in here, but I don't think about surgery until we get a diagnosis. And if you've ever seen a patient with either a primary myopathy or myasthenia, it's really hard to get a diagnosis. Those are not easy things to diagnose, right? So you got to sort of stick through it and get the diagnosis. When we look at the complications from these procedures, they're pretty massive, right? And if you look at the data sets that are out there right now in aggregation, the results are good. But as I mentioned before, our ability to predict results is not that great. And so, yeah, we do need to take really, really careful consideration before we agree to, take someone like this to the OR. And I've got a couple of cases we'll go through here, and I'll show you a couple of successes, and I'll show you one of my failures. And we'll talk about sort of where the thought processes go right and maybe where the thought processes sometimes go wrong. So when we talk about the types of osteotomies, and I'll have a video to show here in just a second about this one. The most common osteotomy for cervical deformities historically is the Simmons osteotomy, which is an extension of a Ponte osteotomy. So the area in black is what's been resected here. So you're resecting the facet of C7, the facet of T1, and then you're extending the cervical spine to create a corrective manipulation or osteoclasis of the anterior cervical spine. So this is for ankylosing spondylitis. And we're essentially releasing the facets in the back and then breaking the neck. And then hoping that that fracture of the neck we can control and stabilize in the OR safely. So in the OR, traditionally, we used to do this in an upright position. We used to have the patient seated in a halo. I have not done this in a long, long time. These patients are all now prone, and I'll show you some more modern examples. But just for history's sake, we used to have these patients asleep, seated in the OR with a halo on, and they were actually awake. So that's this patient giving us a thumbs up. So we had some degree of neurophysiologic monitoring, but early on, we didn't know if we could trust it. And so the traditional answer was to have these patients awake and to do a quote unquote wake up test in real time as you're doing their surgery. So they'd be draped, using a hip drape. You'd open them up under a local anesthetic and a MAC. You get your instrumentation in, you get your laminectomy done, and then you take the halo and you push the head back. You do a corrective manipulation, osteoclasis, the more fancy words you want to use to get that area corrected. And you'd end up with, in a diagrammatic fashion, something like this, where you've got a resection of the posterior elements and then an extension maneuver of the head to try to crack the anterior cortex. Let's see if it works this time. Do you guys turn the volume up on your computer? And let's see if it works. Last year, this didn't work, so I was bummed out, but I think it'll work this year. I'm going to be optimistic. So this is that same patient seated. This is him about to have his head adjusted and corrected. And you'll hear that cracking of the anterior column. And then maybe just give me a thumbs up as we're going if you can hear it, okay? Oh, man. That spinning wheel. Oh boy, guys, sorry about this. 2 years in a row. It was working earlier. Just checked it like an hour ago. Okay, no one's hearing anything, right? Oh, okay. Let's see. Let's see if it crashed my whole PowerPoint. All right, bear with me for 1 second, guys, here. I think. All right, I'm going to have to skip the video, and I apologize. I have a feeling it's going to just keep spinning. Oh, there's a nice cracking sound. If you ever taken have you guys ever taken celery and cracked celery? That's what it sounds like. So this is that same patient I showed you earlier. And again, apologies for the video, but this is that same patient, and you can see a before and an after in terms of the correction that you get. And you get this large osteoclasis where the anterior column just cracks open. And that's where you get your correction. Clinically, what we're looking at here, remember we talked about chin-brow angle. You're trying to get some semblance of where their head is in space. And you can certainly see that his eyes were looking down before, his eyes are looking straight ahead now. But to get really, really specific and really detailed on the restoration of alignment with this is actually a really big challenge because the patient's sitting and you don't really know what they're going to look like when they're standing up. So it gets to be a real challenge to fine tune this. And it used to be fairly common that you would get the correction done. The original papers from Simmons talk about getting the correction done, locking them in a halo, talking to the patient, seeing if they like their position or not. And if they don't like it, you take it back to the OR and you fine tune it. Right. So it used to be a very iterative process. And I don't think we're not there as surgeons that we love the idea of going back and forth to the OR anymore. Patients, I'm not so sure are willing to tolerate it either. And so we've tried to look for solutions on how can we get a better assessment of alignment in the OR. So this was, like I said, early in my career, this is that same patient that we started with, Russell, who came in with that progressive deformity. These are his films, really no flexion or extension really going on in the subaxial spine. Here's his CT scan. Jeremy, you're on there and you're on the spine service. Can you unmute? What condition do you think this guy has?
I think he has, I I think he has ankylosing spondylitis.
Yep.
Or-
Kind of looks, go ahead, keep going.
I mean, at least you can see the definitive line on the anterior side of the vertebral body is going up.
Right. He's got the bridging bone all the way across, right?
Yeah.
And so these, like, we talked about them as like marginal and non-marginal osteophytes. Those ring a bell.
Oh, yes, sir.
So which kind do folks with ankylosing spondylitis have?
I think it's non-marginal or marginal. I mean,
There you go. Somebody's whispering in your ear. I love it. Yeah, marginal, right? But really the picture is more than the words here. The pictures show this flowing bone right across. And then just like we had talked about, these folks can develop global imbalance, right? So let's take a picture, not just of his head and neck, but let's take a picture of his whole thoracolumbar spine. And as we start to consider his thoracolumbar spine and we look at it radiographically, the X-ray didn't pop up yet, sorry. If we look at the chin brow angle, he measures somewhere about 25 degrees, negative 25 degrees from where he should be. If we look at his global X-rays here, we've looked at these earlier, he really doesn't have a thoracolumbar deformity. So this is sort of a real-time application of that framework we talked about earlier. So let's go through those 3 steps again. You know, is this a fixed or a flexible deformity? Jeremy, what do you think? Ankylosing spondylitis.
ankylosing should be fixed.
Fixed, right? Fixed deformity. Is there a global deformity at play here? Meaning, is there a thoracolumbar deformity? Not really. It's limited to the cervical spine. And this is a guy who had no neurological involvement. And if we think about his correction, then it really is talking about a cervical thoracic correction, right? It's not like he has one spot in his neck that's focally kyphotic. And so we've got to think about a cervical thoracic dissection and a cervical thoracic correction. So I took him through that same type of procedure that we just talked about, which is a Simmons osteotomy, posterior laminectomy, and then a osteoclasis and a correction of his skull. And we got very, very good results for him. We got really good restoration of alignment. If you look at his chin brow angle from before to now, right, he's back to neutral. You see that his head isn't as translated as it once was. So we've got his head in better lordotic alignment, better chin brow angle, and we've got less anterior translation. Have we hit all of those numbers that we talked about, like his SVA number, Eric, or his Cobb angle number? We definitely have not hit any of that, right? We haven't even come close to that. And yet you've got an individual who is extraordinarily satisfied with the results of their surgery. Their goal was to look up, being able to talk to people again, be a part of society, eat, drink, not be stuck with his, head stuck down for his whole life. So we accomplished those goals despite the fact that radiographs didn't quite meet our numbers. We're almost on time here. I'm going to skip ahead. All right, let me give you guys a choice. I'll give you guys a choice. So we can talk about 2 things. We can talk about a case where I think I failed pretty miserably in terms of indication and in terms of planning. You always learn from your failures, right? Or I have time to talk through positioning in the OR and how we think about and look at positioning in the OR. So let me get just a hand raised for those who want to do the failure. And then how about positioning in the OR? The people on video, it's tied 2-2. Jeremy, you get to be, oh, David's on also. You guys are the deciding vote. Which case do you want to do?
I'll hear the failure case if you don't mind, sir.
All right. David, are you going to put us back in a tie, or are you okay if we talk about a failure?
I'm on board with that.
All right. And then I'm more than happy to, at any point, guys, go over the positioning any other time. I've got really good pictures, really good things to think about in the OR. Okay. All right. So going to the failures as we wrap up. So complications, we talked about high risk patient population, age, comorbidities, and then the procedure we're taking them through. In terms of unique complications, the most common issue that we'll identify in many of these patients is actually 2 things. One is a C8 or a T1 radiculopathy. So it's pretty common to wake up and have a little intrinsic weakness, to have a little bit of numbness following along sort of the C8 to T1 distribution. And a lot of that's just from the work that we're doing when we do our posterior osteotomies and posterior decompressions. Dysphagia, really common, right? We've taken folks who have had their necks stuck in one position for quite a long time, and we've acutely stretched them out. So it's pretty common to have some transient dysphagia. It's usually not permanent, but it certainly can be an issue. Spinal cord injury is always one of our big fears, right? We're talking about a pretty big correction. We're literally breaking people's necks. And so the concern about cord injury is very real. We have solutions around that, which is, we talked about wake-up tests, doing these awake. We talked about good neurophysiologic monitoring, and then a really good partnership with anesthesia. One of the risks that's been reported historically, which I've not seen, but I can understand the concern, is actually during the corrective maneuver in the seated position, there was a couple of cases of an air embolism that was described. I don't know if I really understand the mechanism for how a correction like this would lead to an air embolism, but it's in the literature. And then the last one is the one to talk about when it comes to failures, is really the loss of correction, the failure of correction, under correction, right? That's probably the most common failure mode that I see when people are trying to take this on, is that we measure with a ruler, we mark with a crayon, and then we cut with an axe in the OR. And so we sometimes lose that vision, if you will, in the OR on that really optimal sort of correction goal that we had. So this is a patient that I really felt bad about for quite a long time, still do, who had come to see me. And the failure here is on a few modes, but let's walk through it. So he's an 83-year-old gentleman. He was a retired ophthalmologist. He had had a number of prior surgeries. You can see his humeral nail. You can see he's had a thoracolumbar surgery. He had a prior fusion up to his cervical spine, up to C2 or C3, I think. He had really severe pain after that surgery, had his fusion, had his hardware removed, except for one screw. I don't know why they left one screw, but they left one screw. And then came to me with progressive worsening pain, and then a progressive deformity, where his head is getting kind of locked down, stuck down into position. Same problems we talked about earlier, has a hard time eating, drinking. But really his main concern was that a really just severe pain, posterior-based severe neck pain. So this is his upright film on the left, his supine film. Remember we talked about cross-table x-rays, bolstered x-rays. The image on the right is with him being supine with a bolster. So this would be fixed or flexible deformity, Gerlach.
He's fixed.
Fixed, right? Totally fixed. That thing's not moving whatsoever. And that's consistent with his prior fusion. Here's his MRI. So he's got a prior, he's got this kyphotic deformity focused right at the cervical thoracic junction, right about here, right? And on top of that, he's got a narrow canal. Neurologically, though, he was okay. So we again see that the area or the locus of deformity. So step number one, fixed or flexible, it's fixed. Step number two, where's the deformity? Is it in the middle of the cervical spine? No, it's probably at this cervical thoracic junction. That's 3, 4, 5, 6, 7, T1. This is T2 to T3, okay? And what I took him through was a T1, 3, 4, 5, 6, 7, 1, sorry, a T2, let's just say T2, a T2 PSO, right? One of the strongest probably corrective maneuvers we have in the cervical spine, trying to get his focal kyphotic deformity at T1 to T3 corrected, right? And I think we did definitely see some improvement in angulation. We had to fuse him up to his occiput, so we got better chin brow angle, mostly through the occipital correction, somewhat through a cervical correction. And so on some respects, his radiographic numbers are better. Are they perfect? They're not perfect, but like we've seen before, you don't need perfect radiographic numbers to get good clinical outcomes. And the reason I label this as a case that I learned a lot from and that I think of as a failure is that this is an individual who had horrific neck pain preoperatively that I truly probably didn't grasp well enough, and had, not surprisingly, even more horrific neck pain postoperatively. We found out afterwards that he was taking Dilaudid at home. He was giving himself intramuscular shots of Dilaudid at home prior to surgery. And we didn't have eyes on that until afterwards, right? So I don't think we undercorrected him for sure. I may have underestimated the extent of the deformity in the sense that he needed more correction than I could have accomplished with a single level PSO. But we also did not have this gentleman optimized at all, right, prior to surgery. We had a lot of noise in treating him, specifically around the pain and pain medications. And so while he was very thankful and his pain eventually got back to baseline, he was happy with his head alignment, but he never really got his primary goal of surgery, which was pain relief. We never really helped him with that, right? So I would label this as probably one of my bigger failures. Nothing catastrophic happened, but it's still a failure on a number of different levels. And it just was a reminder to me, and I always include this because it's a reminder to me to make sure I convey to you guys, these are complicated patients. This is really complicated decision-making. And so understanding that these pitfalls exist there are going to be really important. All right, let's wrap up. Almost on time. So a couple of conclusions. Cervical deformity, uncommon, but really high impact on patients. We have yet to really understand why deformity occurs. And we have really yet to understand why it impacts some people more than others. Remember, we talked about those 3 key steps, right, in determining treatment: fixed or flexible, local versus global deformity. And then thinking about, based on those 2 things, what's my surgical approach going to be? And then correction is always a matter of risk and reward. There's this constant assessment you've got to go through as you see these patients, balancing risk and reward. And then thinking about how we obtain strong fixation and good, safe surgical techniques. We didn't talk too much about that. We're making the assumption that we're solid there. But that's obviously super important, right? Identifying optimal points of fixation, bone health, getting really good correction, really good rod alignment, really good mechanical reconstruction after you've done the deformity correction. I think that's it on my end. That is, again, that is 15 years of my experience in cervical spine deformity, tried to summarize in an hour. So what thoughts, questions?
I have a quick question. I mean, it might not be a more like deformity question itself, but in terms of folks that are myelopathic that have, preserved lordosis, that don't have a lot of axial neck pain, and you choose to do laminoplasty. I was reading a paper and they were talking about, how the C5 nerve root palsy is like 5 to 6%, for folks that undergo that, and it'll, comes back over 6 to 8 months. Do you feel that there is an area where you could do a prophylactic like C4-5 foraminotomy? Because I remember reading a paper that showed that there was, the incidence was basically cut down by like 70%.
Yep.
And I feel like the morbidity of having like a 2 out of 5 delt bicep strength for 6 months is pretty real.
So Eric, lots to unpackage there. So C5 palsies do happen. They happen with cervical laminoplasties, laminectomy fusions, ACDFs, right? We don't really know the cause of a C5 palsy. We think it has something to do with how much cord shift there is. Maybe that's putting tension on the C5 root, we think. In terms of preventing C5 palsies, foraminotomies have been shown. As you mentioned, there's a couple studies that have shown a reduction in the amount of C5 palsies by doing a foraminotomy. So I'll always do a 4-5 and actually a 5-6 foraminotomy because I've seen C6 palsies as well. There's a couple of newer studies that have come out that I can't say definitively yet, but actually suggest a lower rate of C5 palsy with laminoplasty than with laminectomy and fusion. There were a few papers out of the CSRS this year that showed that. And the theory there is that maybe laminoplasty prohibits the amount of cord shift that can occur. If in a laminectomy, there's nothing stopping the cord from floating back. In a laminoplasty, maybe you're getting a little more control over the amount of shift in the cord. And maybe that affects less of a C5 palsy. And it's been seen enough times now that I'm thinking out loud and doing the following, which is in a laminoplasty, I'm not aiming for maximal correction. I'm not going for a 14 millimeter correction. I'm usually going for a relatively modest amount of laminar opening, trying to minimize cord shift. But those are the short answers to that, the long answers to those questions. A couple of these patients, and we've got a series I've got going with Dr. Ko, which we probably should figure out and write it up, because he's been seeing these patients early on with really dense C5 palsies. So these are folks who have zeros or ones post-operatively. And he has been actually, if they don't get better by 3 months, he's been doing transfers. He's been doing radial nerve to axillary nerve transfers. So I know we've got at least 4 or 5 patients of mine that he's seen over the years, and I know he's seen a few others. And the functional restoration is pretty impressive, right? These guys get return of overhead function pretty nicely.
Thank you.
Absolutely, buddy. Good question. Other questions, other thoughts? As far as testability, most of this isn't going to be on your in training or on your boards, except for talking about some of the maybe causes of deformity. That's likely to be on there. I think understanding a little bit about how sagittal alignment in the cervical spine and the thoracolumbar spine may relate to outcomes will be on there. A lot of the things we've talked about in terms of this more level, like this higher level of complexity of decision-making, won't be on your boards, but I would argue pretty strongly that you'll identify other aspects within orthopedics where you've got really complex problems. And I'd encourage you guys to try to think of frameworks as you move along that you can go back to. Like I go back to this mental framework I have: fixed versus flexible, local versus global, driving my choice for correction every time I see somebody with a deformity. So I'm not reinventing the wheel each time. And I bet you that same concept of a framework would be really valuable in other subspecialties. All right, guys, I'll let you get going. Thanks for your time tonight.
Thanks, Dr. Patel.
Thank you.
All right, so.
All right, bye, everybody.